Sorry. I just wanted to mention that if you register for the Maine Orthopedic Review, there's no financial commitment until spring, but it's really important if you want to get updates from us, know what's going on, and get our information that you register. This also prevents you from ending up on a wait list, which is really important because many times it's very difficult for us to get additional faculty late in the game. So if you have any inkling about coming, please register. We're at a new venue this year. We're very excited. It's at Endicott College, just outside of Boston. Very easy to access via the Boston transportation hubs. It's about 35 minutes by Uber, and it's right on the ocean. Great accommodations, private rooms, private bathrooms, and there's a meal and room plan that just is unbeatable for the price for 5 nights for about $715. This year, we also have 4 great additions to our faculty. In addition to some of the people here, Dr. Richard Ma, he's the head of sports medicine at the University of Missouri. Dr. Lee Rubin, chief of arthroplasty at Yale. Dr. Michelle Bramer, who is chief of trauma at WVU. And Dr. Hans von Lanker from Harvard are all joining us this year. So we continue our tradition of really strong and accessible faculty. And we're the only place where the faculty will go through all of your cases. So without further ado, we'll talk a little bit about ABOS Part 2 and logistics of Part 2. As you know, you submit your cases through Scribe. The board takes a look at a 6-month window of your cases, selects 12 of them, and you need to bring these 12 along with any, you need to be prepared to speak about these 12 along with all associated material at the boards. And at this point, what I'd like to do is introduce Dr. Aaron Johnson, who will be talking a little bit about the logistics and how to prepare for kind of uploading and preparing your cases. Aaron.
Thank you, Bruce. So I guess there's 2 sort of parts of what I'll talk about. The first is when you're in your 6-month case collection, which, if some of you are just starting that, then hopefully you're not too far behind already. And those of you who have already been through it, you know some of the pain of doing this. So there's a system called Scribe, which is a website through ABOS, and you have to enter all of your cases into it. I'd recommend staying on top of it. What I would do is I would come back, I'd write my op note, I'd put my case in our billing database, and then I'd put the case into the ABOS website. If you miss a week, it's amazing how quickly you can get behind and how much of a burden it can be if you don't, because the system is somewhat cumbersome. So the more you can stay on top of it, the better. So the things that it asks for, the main things are there any reoperations? Are there any readmissions? And then what sort of complications you have. And if you go on the ABOS website, they have a sample list of everything, but it's in general, it's anesthetic, surgical, and medical complications. Reoperations are just that, right? I mean, if the patient has a reoperation, if you have to take them back to the OR for anything, it's a reoperation. Readmissions can be a little bit more difficult to find depending on what sort of hospital system you're in. If there's a lot of different hospitals in the area, they want to know a 90-day readmission for anything. So some of that can be a little bit of a logistical nightmare. For us, we have, in the state of Maryland, we have an EMR that accesses most hospital systems for us. So I would just try to go back and check periodically, sort of at that 90-day mark. Most of the readmissions you're going to know about, but there may be readmissions for an MI, a DVT, a C. diff, something that you didn't know about the patient. You may have even seen the patient in follow-up and they didn't mention it to you that they went to an ER, stayed at another hospital while they were in DKA, and then they came to their 6-week follow-up with you. It was somewhat eye-opening for me to go through as I was seeing all this, I'm like, oh, I saw this patient yesterday. They didn't mention any of this to me. So the more you can scrounge around on other, whatever you have access to through your EMR is helpful. And then I always get a lot of questions about what do you consider a complication? What all do we have to put down for these complications? I think use your judgment. If you think about it and you're questioning it and you wonder, should I put this, should I not put it, err on the side of putting it. The converse of that, if you have a patient whose creatinine bumps from 0.7 to 0.9, you don't need to list that every single time. If you have somebody that goes into renal failure post-op, you should put that. The logistics of getting all of that can be somewhat of a nightmare, but it is what it is. You got to do it hopefully once, and that's it. X-rays are sort of next on the list of things to chat about. I guess, does anybody have any questions? Has anybody started using the online case entry and had struggles with it, or have you guys all finished your case collection and this is not necessarily relevant?
You can raise your hand or put a message into the Q&A box for any of us at any point. Aaron, how do you go about dealing with images or notes from multiple hospitals? How about if they come from out of state? What do you do?
It's a good question. So a lot of my patient base comes from all over, since we are sort of a central tertiary referral case hospital. From an X-ray standpoint, right, so these are for your 12 cases that get picked. You need your pre-op X-rays, you're going to need your immediate post-op X-rays, and then whatever you have at most recent follow-up. Advanced imaging can be hit or miss. You don't need to upload 1,000 images from a CT scan, but choice images, sort of critical images, something you may not be able to see on a plain film is going to be useful. If you are more sports oriented or spine, right, you're going to need MRI images that are representative of whatever it is that you're dealing with. Once I got my case list, I just sort of sat down and tried to batch all of the X-rays. We have 3 main X-ray systems that we use, but if you're operating at a bunch of different hospitals, you may have a lot of different EMRs, a lot of different radiology places. You may have outpatient clinics that you have radiology sites that don't integrate with your EMR. There's lots of challenges that you can come across. So I would take the time now while you're not sort of in crunch time to make sure that you have remote access to all of that, so you can sit at home in the evenings and be able to log in and get access to whatever images you need. From a nuts and bolts, sort of how did I collect my images? Most X-ray imaging sort of radiology programs have an option to take all of the patient identifying information off of it. So take some time now. If you don't know how to do that, familiarize yourself with how to do that. As you're going through and collecting your images, I would de-identify everything through the software, and then I would just take a screenshot and capture it on my desktop. And then from the screenshot, I would upload that onto the ABOS website. From a note standpoint, you don't need to go crazy with the notes, but you do need your most recent note prior to surgery. So if it's an elective case, you're going to want to upload the note that you wrote when you were in clinic. If it's a consult or something emergent or a fracture case, you're going to want to upload your consult or your H&P from before surgery, and then your op notes. And then I believe you need the most recent clinic follow-up. So those things, hopefully you have access to all that stuff. The way I would do that, or the way I did it, was I printed the note to a PDF. I then had a PDF of the entire, however many multiple notes that I would combine into one. And then you can go into Adobe and Control F and find all of the patient identifying information, whether it's date of birth, name, etc. And you can sort of black it out. You can do it the old school way. You can print everything out. You can take a black Sharpie to it and then scan it back in. But everything does have to be de-identified, and that can take a little bit more time, right? So it takes some time to gather the stuff, to download it, to get it in the acceptable format that they want, and then to de-identify everything.
Thank you, Aaron. Let's move on to Mike O'Malley. Mike, I'm going to give you a few minutes to talk about logistics, and specifically logistics for sports guys who tend to have hundreds of more images than anybody else other than the spring guys, looking for the ever elusive pasta lesion.
Yeah, no, so good evening, everybody. Thanks for joining in advance. This is a really good, I will tell you, I did this course. It's very, very good. So you're in a good position. You're setting yourself up in a good position to do well on this. But some of this might be a little bit redundant from what Aaron said. I'm going to kind of touch base and talk about what images are pertinent for certain providers. What kind of notes, what consultant notes are necessary, things of that nature. So first and foremost, I just want to throw one note out there that, the Cleveland Browns are playing this weekend, as you can tell, and any Steelers fans can now log off. Just kidding. No, but for the imaging, all jokes aside, for the imaging, it's very important that you include basically the pertinent positive and pertinent negatives. Think of it that way. So you're telling a story, essentially, is what you're doing for each case, and you have 10 minutes to do it for each one. So it's not a very long time. So, and I will tell you, it goes by very fast on test day. So, when you're going through your cases, you want to make sure that you only upload the images that really have some sort of effect on your case. For instance, an ACL tear. I will use sports as an example because that is my area, but an ACL tear. You do not need to include every single coronal, axial, and sagittal image on the MRI to state that the patient has an ACL tear. You can go to your appropriate cuts, on that sagittal view, take a couple screenshots to show, the ACL if it's pertinent. If there's a meniscus tear, you can go to a coronal or or a sagittal cut. Or two, to show that meniscus tear, but you do not need to go through every one. Show, which ones show the pathology the best. Take those screenshots, and then you can upload it, onto the system. I would say for each of my sports cases, I tried to limit it. I tried to keep it to about maybe, 4 to 5, MRI images and the appropriate x-rays and stuff, because it's very, very easy to get bogged down. Very easy. The extraneous images are not needed, for this. I think, when you're thinking about your cases, think about it like you're presenting at a fracture case in residency or a fracture conference in residency. You want to include the pertinent, pre-op x-rays, pre-op imaging, advanced imaging, whether that's an MRI or a CT scan, whatever the case may be. And then you're going to need to show any pertinent intraoperative imaging. So for those going into trauma, that would be your, intraoperative fracture care. For sports people, that's arthroscopic images. You need to, what I did for my arthroscopic images is I did not just take pictures of, pages that had 6 pictures on it, and they were super small and you upload couldn't see. I would take individual pictures of the time points during the case that pertains to the surgery itself. You don't need to upload diagnostic arthroscopy pictures for every single scope case. If it's an ACL tear, you show the ACL pathology, you show your drill tunnels in an inadequate position, you show your graft, things like that. And that way, it's easier to navigate, that your story is more concise. And you're able to get through it, and the people that will be listening to your case will be able to follow it much easier. And again, you don't get bogged down by the minutia, because there's just no time for that. I would say you need to include, with those imagings, you need to include your reports. So you need to include your op notes. I would actually make the point to include any reads by the radiologist, and your own formal interpretation of that imaging, because sometimes there is discrepancy. And I would include that discrepancy, in your presentation so that, it is there. But in regards to the imaging studies that you need to upload, just make sure you go through each one of your cases, and you will get a sense, the more you go through it, of which images are actually needed to tell your story. And it's just through repetition will you know. So just in summary, pre-op x-rays, pre-op advanced imaging, okay, MRIs or CT scans, intraoperative imaging, okay, and that includes arthroscopy pictures, and then post-ops, especially your most recent post-op, for your follow-up. Okay, so I think that's a good way to kind of to break it down and the important stuff to include. As far as the notes, again, the notes, I mean, the first time I went through mine, it was like piles of notes, right? And you're like, how is this even possible to get through? So you need to make sure that you include one, your initial consultation. And then if you see them, again, before surgery, any conversation that you have, regarding, their surgery. If it's an outpatient procedure, again, you got to include your op notes, and you got to include, your follow-up visits. For sports providers, for hand providers, you don't need to include every single physical therapy note. You don't need to include occupational therapy notes. Those are not necessary. Okay. You just need to make sure that you're, documenting in your notes that, they are working with physical therapy, and they're making, progress, within your protocol, and so on and so forth. But physical therapy notes, occupational therapy notes, not really necessary. For those providers that do have inpatients, you don't necessarily need to include, like, for, I know for some joints, every time they're admitted, they just immediately get like a medicine consult. This is they're following on board. You don't need to include that unless it's really pertinent, right? So like if you do have a patient that, God forbid, has to stay in the hospital for a few days, maybe they had some sort of a complication. Yes, I mean, say it's a post-op PE or a post-op MI or something like that, I would include that cardiology consult. If it's an infection, I would absolutely include your infectious disease consult, what the plan would be, and so on and so forth. And even even their notes and follow-up, if it's on your record, if they're within your system, I would get your hands on their notes, because I think that's pertinent to that particular scenario. I know I did that, and there was questions asked on that. Okay, so if it's an infection, I would make sure you include that in there. And it doesn't necessarily have to be every one, but just documenting what their plan is, and so on and so forth. But every consult does not need to be uploaded on there. It's just too much paperwork, just what's pertinent to that specific case. And then for follow-ups, I will tell you that follow-ups are good. Obviously, they want to see you following up on your patients at appropriate time intervals. I have come across in years of doing this that sometimes follow-ups aren't even possible. For those in the military, they will operate on somebody, they'll never see them again. And you just have to disclose that and just say, this was performed when I was in active duty, and the patient was not available for follow-up, and they understand that situation. But if you do see that patient in follow-up, you just need to make sure that you include your note, and then any imaging that was obtained, especially for fracture care and stuff like that. For anything we do for spine and stuff, you just need to document your hardware is doing okay, and the patient's doing okay, and so on and so forth. Again, for those patients that did have complications, you may want to think about, you can document it in your notes, and that might be sufficient, but you may want to think about including, whatever consulting service did see them in their own follow-up, such as infectious disease or such as cardiology. I don't know if it's completely necessary if you're documenting in your own note, but if you don't feel comfortable with your own documentation in those circumstances, which like I would document like ESR and CRP and the patient's improving, but like that's not overly specific. You know what I mean? Like you may want to include that infectious disease note too and follow up. So that might be a good idea. So the biggest recommendation I could give you guys, for this test is you need to just go through your cases over and over and over and over and over again. Go through it with people that don't know you, offer to present it to whoever, present it to your family member, present it to whoever, because the more you go through it, the more fluid it's going to be. You're just going to get into a rhythm with these cases, and you're going to see how they should go in sequence. And that will help you understand, what exactly to upload, when the final upload is necessary on the system, which images, which notes and stuff that you will need. Right? If you just do it once, it's not going to be enough. You got to do it over and over and over again. So I
Great,
hope that
thanks.
was helpful.
Thank you, Mike. I do want to expound a little bit more on something you mentioned, which was people lost to follow-up, not only military, but a lot of times trauma people or,
Absolutely.
just patients in general are just lost to follow-up. And that seems to come up every year. So how would you handle that if,
Yeah,
let's say
it's
you
a great
operate
question.
on somebody, saw them once and they couldn't find them again?
Yeah. So we had a process. So I've been in two separate practices now in my short career, but in both practices there is documentation where the office does document that they attempted to contact that patient, for their no-show visit or for whatever. And I would absolutely include that in your thing if they did not show up to their follow-ups, once, twice, three times or whatever. I would include that to say that like we tried to attempt to follow up with this patient, but we could not get them in the office. We tried to reach out multiple times. And I think they're understanding of that. I think it happens, quite a bit, especially in certain, patient populations, but that's what I did. I had a specific case that, I had a patient that followed up once and, never saw him again, despite our intentions of getting him back in the office. And I just included those, that documentation that we did it, basically like every other week. We sent out a reminder to them and they just never showed.
Yeah, I think that's a good point, Mike, that most offices have a protocol. And so you don't necessarily need to share every letter you sent the patient, but know the protocol if they're lost to follow-up. Great. Thanks, Mike. Next, I'm going to bring in Michael Blankstein. He's with us from Blankstein Studios in Burlington, Vermont. It's lovely to have you here, Michael, and going to have you spend about 15 minutes talking to us about organization of the cases and then something that I think is very important at the end, if you just touch on complications.
Thank you, Bruce, and thanks everyone. This is probably on the one hand the most stressful exam you'll ever take. On the same hand, I can tell you it's also the most fair exam you'll ever take. So you gotta follow the advice that we're giving you, because it turns out we're not giving you any specific advice about how do you present this fracture as opposed to that fracture. The most important thing here to understand is that it's all comes down to the preparation. I really like what Mike said now, which is actually something that we've realized during the course, is that some people don't upload all the necessary images. And by the time they see us for the course review, right before the exam, if I say, oh, you have a CAT scan, they say, oh, we didn't upload it. It is nice to practice the exam before you even submit your final images, so you know which ones need to be uploaded. So that's very important if you can. So you have to understand that the examiners are seeing your cases for the first time the day of the exam. They're not reviewing it the night before. So it's really important to understand that, again, the ball is in your court. And if you make this story easy to follow, they're more likely to actually follow and enjoy the story. Okay, so you're telling the story, you know the cases. If you do your homework, this will be the most fair exam you'll ever take, because again, it's all cases that you know, it's complications that you know, it's history that you've taken, it's cases that you've actually operated on. So I want to say again that the practice is everything here, practice and organization. Another piece of advice I want to share with you is the fact that you really want to share this exam, just like Mike said, even said with family members, but even with colleagues you are not in your subspecialty. For example, I'll give you an example. I wanted to present my case to one of the upper extremity surgeons just because I wanted to get one more chance to go at it. And then he started asking questions about my DVT prophylaxis protocol for those patients who have AFib or were previously on Eliquis. And I didn't really remember. An arthroplasty guy may not even ask you that if they might not be interested in talking about DVT prophylaxis, but the fact that somebody from another specialty asked me made me realize that I actually didn't know the protocol as well as I should have. And that triggered me going down that path. So again, be prepared and practice as many times as you can with people in your department, with friends from residency, friends from fellowship, etc. So Ken, so let's talk about being organized. Do you really want to show that you know the foundations, and the foundations are doing a good job with your history and physical before you get down to the specifics? So show them that you know what you're talking about. One of the things that I really do not enjoy when we do the prep during the course, the main review course, is that people would tell me the whole story and then the whole time just staring at the blank screen, and then finally they show me the x-ray. So you should probably start, the first x-ray should come with the presentation as you're starting. They always want to be looking. We all like to look at images. So just, show it, if it's a lady who came in with a hip fracture, start with the fracture, show AP pelvis showing the fracture. Now they know we're talking about a femoral neck fracture, and then it can start into a 65-year-old female, low energy fall, history of da 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 da. This is what happened. This is when she came to the hospital, etc. Um, don't gloss over the fact that if you do a good job at describing your history and physical, you're already getting points. If you actually skip that and you don't give them the pertinent information, then the questions are already building up, and they're also not following this flow of your story. Um, and certain things you want to offer right away. So if somebody has a cardiac history, you can offer and volunteer the fact that preoperatively, we obtained a medicine consult. We obtained a cardiology consult. They recommended XYZ. And you don't want to wait for them to start asking you the questions. Because if you volunteer all the necessary information, you just sound and look like a pro, and they're more likely to actually have a good conversation with you. One of the things that's really important is to follow the story in a chronological order. So if somebody came in 3 days, if somebody comes in with a fracture and they actually have had the injury, like let's say 3 days ago, start with the initial injury and then showed what happened post reduction, etc. So one of the things that we saw again during the board review is that people who haven't practiced, you can see that the story is not following the images, right? They're already talking about their intraoperative, they're talking about their plan or intraoperative process while I'm still looking at x-rays of the initial MRI. So make sure that you really have the two connected. And this is again where the practice comes into mind. Again, we talk about post-op management, volunteer the things that are important. So when we completed the operation, we got post-op images and recovery. We allowed the patient to weight bear as tolerated. We continue with DVT prophylaxis, antibiotic management, PT, etc. You volunteer that, you sound like you know what you were talking about. So usually if you do a very good job and you're very well prepared, there will be hardly any questions for them to ask you when you're done telling the story. And then you can have a very educated conversation about, hey, what are the various treatment options for treatment? Why would you choose this implant as opposed to that? As opposed to them asking you about, hey, why didn't you obtain a CAT scan before? Things like that. Um, if there's something you don't want to talk about, there's also an art to that. And in theory, there's certain things you may not want to get into, and there's a chance they're never going to talk about it. So let's say somebody had multiple injuries, but you operated on the hip, for example, yet you really don't want to get into the fact that they also had, like, let's say, an undisplaced pelvic fracture. You can tell them what's happened, what the injuries were, and then you can talk about it. Then you get to redirect to where the case is going. So you're in control of the story, Again, if you practice and you do it with style. Um, with respect to the relevant images, of course, you want to show all of them. Again, when you see people are disorganized, what happens is they'll put up all these images, and then when they tell you the story, they actually don't show you the CAT scan that they loaded, right? So if you have an image that you uploaded, you want to make sure that every single one of those images that you have chosen to upload will be displayed during your story, as long as you're practicing and the two are coming again, are showing up at the same time. So if you have again, if you order an MRI, you can show the certain cuts that are important, and again, you want to do that during that part of the conversation, not when you're going to the operating room. The same with the intra-op images. As you're doing the story, you let's say again, you're nailing almost every single examiner we've ever seen deals with a hip fracture. So yeah, it's a perfect example. If let's say you put in a short gamma nail, it'd be nice to say, we placed the patient on the fracture table. We were able to obtain a good closed reduction with some traction, internal rotation, and then you show the closed reduction x-ray before talking about your starting point and actually putting the implant in. And the same with the follow-up. So that's pretty much it. As you can see, there's a very strong theme here, which is if you rehearse telling the story and the actual encounter, you will do just fine. So the biggest question then is, what do you do when you have complications? This is where everybody stresses the most. And all I can tell you is that you don't need to stress if you've prepared. So we all have complications. They choose the complications, right? Is that true? They choose half of the cases will be with complications or something like that?
I don't
Bruce?
know if there's a dedicated number,
Yeah.
but they're very good at choosing complications.
Exactly. They look for that, right? Because it gives them an opportunity to see who they're dealing with. Not because they're worried about you having complications. The key is to find out why you had them and how you dealt with them and what you learned from them. So the fact that they've chosen, they're for sure gonna choose that one case that you're stressing out over. They're for sure gonna choose that one difficult, rare case. That's what the exam is for. But don't stress out, expect that. And what you need to do is be organized and explain what you did and how you did it and why you did. So you have to be honest first and foremost. Be honest, admit the fact that if let's say you forgot to do something, it's okay. You can say, hey, in retrospect, I wish I would have done this differently. I should have ordered this, etc. One of the things where again it's so valuable to talk to other colleagues is, how do you address these complications? And as you speak to other colleagues, you'll see they'll give you very good advice. And that's why the main orthopedic review board review course is so good, because you have an opportunity to see so many people presenting their cases and how they deal with it, and you'd also get a chance to present your cases multiple times. So the key is to see, to demonstrate that you're aware that you made an error. Sometimes it's your fault, sometimes it's not. If it's a complication, we all get complications. Sometimes it has nothing to do with you. If you give somebody DVT prophylaxis and still get a blood clot, then there's nothing you could have done. But obviously, if you missed an occult fracture, then that could be a big deal, as long as you demonstrated you understand that this is something that was an error of omission. So tell them what you learned and then take it to the next level. You can say, well, ever since that happened to me, I no longer do this. Then I instituted new pathways and protocols, or this is every time since this happened, I make sure I order XYZ, and this is how I deal with this. On top of it, again, in the end of the day, it's all about being safe and it's all about the patient, right? So if you tell them that you had a complication and you sat down and you spoke to the patient and the family and you explained what happened, and then you chose to do the right thing, which is, hey, we may have to go back to the operating room. We may have to revise this. We may have to consult another person. It shows that you care. And in the end of the day, you're safe, because we're all going to have these issues. So I think I'll stop here and then leave it for questions.
Thanks, Michael. I wanted to hit on a few things that people have talked about already. One is that it is important to demonstrate that you're safe. I think one of the real focuses of the board during their questioning and review of all your material is making sure you are safe and ethical. So if you have any problems with feeling like you're unsafe or unethical, I would definitely review those issues with as many people as you can. I think it's another real focus of the board to make sure that we present ourselves as excellent physicians first, not just orthopedic surgeons, so that if you do have a patient that has significant underlying medical issues or issues in general, they are not expecting you to be experts in all of those issues, but they do expect you to make sure the patient is getting taken care of and that you're an advocate for that patient. The other thing I wanted to say is it's really important. I mean, people talked in general tonight about ways to present your cases, but I think it's really important to know on a very detailed, granular level what's going on with your patient. So if you're using a specific implant, or you're using a specific antibiotic, or you're using a specific type of therapy, you need to know about those and why you're using them, what the upside is, what the downside is. They want to know how you think in terms of taking care of your patients. I wanted to present another question to our panelists. I'm sorry I'm putting you on the spot a little bit, but your top thing somebody shouldn't do in preparing for the boards or during the oral boards, what would that be? Mike O'Malley.
In preparing or when you're taking it?
Preparing.
That you wouldn't do?
Would not do.
So I certainly wouldn't take the process lightly, right? So it's very easy to just say, oh, I got plenty of time to do this, right? And for all you procrastinators out there, try to cram this stuff in, and I'll catch up with those op logs, Zarin was talking about before, next week. I'll just do it next week. Do not do that. You don't want anything. This is like the one time in your life, in your career, that you don't want anything falling through the cracks.
Great response.
Yeah, because it'll get exposed. So you just want to make sure you just stay on top of things. It could be a little bit cumbersome at first, like until you get into like a bit of a routine, like when you upload things and stuff like that, and getting used to that. But just do not blow it off. Don't put it to the next day or the next week. Just stay right on top of it, and you'll be in better position as you start to prepare.
Yeah, I think that's a great answer. There's a lot of information that people need to cull, and it's really important to just keep plugging away at this. How about you, Michael? What's the top thing somebody shouldn't do?
Don't do it alone. What I mean by that is a lot of people have gotten to where they are by just being able to study independently. It's okay. The part one, you could just sit in the library by yourself and study. This is not something you want to do alone. This is something that really comes down to your presentation skills. And if you think that you're going to do a good job practicing by yourself and rehearsing it, it's just not going to be the same as doing it live during the exam. So you really have to recognize your own deficits when you're presenting the story to be able to connect with the examiners, to be able to show that you're demonstrating knowledge of the entire scenario, and you don't realize how much you don't know or how people are reacting to what you did until you showed it to so many people. Again, this is something that you want to practice at least with 10, 20, 30 different people where you're telling the story and see how they interpret what you've chosen to do. And it's amazing. Not one person that helped me practice for the exam did not provide some sort of insightful information.
Great. Thanks. Aaron, I'll put you on the spot. What's your one thing not to do?
Well, don't procrastinate was going to be my one thing. So I tried to come up with a couple other ones. So something that I occasionally hear is I had somebody else pull all of my stuff and I don't know why this isn't in there. Don't have somebody else do it, right? Like saying I don't have that x-ray because my secretary didn't upload it, like that is not a good reason to not have the post-op film. Just take some time, do it yourself. Another thing, which is sort of a brief, I couldn't narrow it down to one, so I'm giving you two. Sorry, I'm not following directions. But don't argue about complications with the reviewers. I've seen a few summers now of people giving their presentations and arguing about indications and arguing about complications and whether or not you didn't do something wrong, that won't get you anywhere. There's one in particular that I remember. Somebody had a patient with no radiographic knee arthritis that was scoped, that allegedly had kissing lesions in the scope that they then put a knee replacement in that had complications afterwards. And the applicant was arguing with me that it was an indicated surgery and there was no radiographic indication of arthritis, right? Don't pick that battle on test day, right? I mean, hopefully, to echo what everyone else has said, give these presentations to multiple people. Get as many people that you can to listen to them, and hopefully someone will give you some advice like, hey, your indications may have been difficult or sketchy on this case. You need to have a plan to address that, and arguing with the reviewer or the examiner is not the right thing to do.
Yeah, good point. Good point. I think it's, and another thing that I've seen over the years is people not operating for the right indications, like you mentioned. So you have to have a strong indication for operative management. And also you have to do the right procedure for the right diagnosis. Do not attempt to make up a procedure and try and get away with it. Stick to your guns, have the right diagnosis, the right indications, do the accepted procedure, the traditional procedure, and I would avoid any controversial types of procedures during your board collection period, unless you can back that up with significant literature. It's not the kiss of death, but I personally, as an arthroplasty surgeon, wouldn't want to go in with, say, a metal-on-metal hip these days. So, just think about what you're doing. Do the right operation for the right reason.
Hey, Bruce.
Anything else?
Hey, Bruce,
Yeah.
just one thing. We talked about what not to do in preparation, but what not to do during the test is 100% when Aaron said, do not be confrontational with your examiners. That's the easiest way to fail.
They
So
do like to kind of knock you off your
they
game.
they want you to bite. They want you to do it. They're trying to do it. So just, take a step back, take a deep breath, whatever you got to do, just approach these cases and the situation with humility, and just take one step at a time. Do not get in a situation where it gets confrontational during the test. Cause that's kind of, that it won't bode well for you when it comes to, the grading and so on and so forth. So yeah, thing to avoid during the test, that would probably be my number with that, and being dishonest. If you make a mistake, just admit it, just own up to it. That's what they want to see. They want you to see, honesty, integrity, approaching, take the fact that you have your patient's best interest at mind. If you happen to make a mistake, everybody makes mistakes and make them every day, but just own up to it. That would be some good advice, I think.
I think you brought up a good point in terms of confrontation. It's probably the rule that they are going to push the presenter to the point where they just don't know anything further. And sometimes people can get very emotional when they get kind of at the end of their rope. So it's really important to be able to keep your emotions in check, remain professional, ethical, and present the facts as a physician.
And it's okay to say you don't know.
It is okay.
If they ask you a question,
I've never had to say that, but
yeah, Bruce, no, yeah, never been in that situation. But it's okay to say you don't know. I had like people ask, because like the couple of cases were easy scope, cases. So I had like 3-4 minutes left over, and they would just start asking me questions about aspirin's mechanism of action and all this stuff. And it's okay to say you don't know, and you'll get back to them and stuff like that. So
but you also hit on a good point, and that is, like, if you're ordering a medicine, you should
you should
know
know it. Yep.
the mechanism of action. That's a fairly common board
Especially
question.
the most important medicine of all. They won ANSEF.
Mhm.
Right. ANSEF is important.
Here's everything.
But I wanted to thank all of you guys again. It's getting close to time to wrap up. I just wanted to give another opportunity if anybody wanted to give us a question in the chat box. Happy to answer any questions. While we wait the next few minutes, I'll give you a little bit of a rundown about our course this year. This year's dates are June 17th to the 22nd. And for the Part 2 exams, we typically like for the candidates to be there for all 4.5 days. And like Michael said, at our course, not only do you get through all of your cases, but you really get to audit very similar cases that others bring. So it's really a valuable 4.5 days where you really get an opportunity to organize your thoughts and your presentation. And half the battle is just being able to present your case in a coherent, thoughtful way, and without really getting thrown off track by a question here or there. So it's really important that you get through all of your cases, and we're happy that we can do that for you. We have about 40 faculty from all over the country. Some of the best ones are here, but we also have people who've been with us for 30 years, who've been academicians for a long time. We have people who are fresh out of the boards, and everybody in between. It's a really great way to brush up on your cases and make some new friends, and really get down to the nuts and bolts and nitty gritty of your case, and really get perspectives from many different people on how your cases should best be presented so that you'd succeed. We have a very favorable track record, and I think everybody here would attest to the fact that all the faculty are committed to help you get seen in the best possible light. Like I said, this year we're at a new venue at Endicott College, and we're very excited about that because it'll be easier to access than our typical venue in Central Maine. So it's only about a 30-minute Uber ride from Logan Airport in Boston. And the entire venue will be upgraded. We'll have very comfortable accommodations, even though they are still dorm style accommodations. But the meal service is excellent, and the price for 5 nights is really unbeatable. We have great faculty, and of course, we would be remiss if we didn't mention that on the Friday night of the course, we invite everybody to a giant lobster bake, which is included in your price. So If you know anybody or you're interested, please register soon so you're guaranteed a spot. Because if you end up on the wait list, it's not very common that we have an opening, and we pretty much always fill the part 2 section. So we're at capacity faculty wise. So don't wait. You can register on our website, mainorthopedic.com, and I'd be happy to handle any emails or calls if you have individual questions. My cell phone number, if you have a pen handy, or even if you don't, this is my cell phone number. It's 207-377-5777. I'm happy to take questions if you have any. My email is director@mainorthopedic.com. And I'm sure any of us, if you wanted to email to ask for advice, would be happy to help you guys out. So
Bruce,
Looks-
there's a
looks like
hand,
what's that?
there's a hand raised, but I don't know how to let
There's
them.
a hand raised.
Yep. I assume that means someone has a question.
I don't know how to see. Where do you see that?
Next to the participant list.
Participant list. I have a chat box. Okay, I see a hand raised. It's Akshay Goel. I'm going to allow them to talk. Akshay, come in.
Yeah, can you hear me?
Yes, thanks
Yeah,
for
thanks
joining
for
us.
seeing that. I appreciate you guys doing and taking the time out. So 2 questions. The first one is, so I've already finished my case collection, and hopefully if I'm approved, I look forward to attending the course and getting done. But sorry, it just asked me to cancel something. Anyways, so if I have a mix of joints, trauma, and then some knee scopes and carpal tunnel, stuff like that, when I'm doing both the main review course as well as in the boards, will I be presenting like my knee replacement patient to a joints guy, my trauma cases to a trauma person, or it can be any, like, how does it work for a general orthopedic
Can be
guy?
anybody.
So I can tell you at our review course, you will only present subspecialty specific cases to the appropriate subspecialists. So you won't present a joint case to a hand surgeon. It's all mapped out. We spent a lot of time going through all these cases and scheduling everybody so that you will only be in front of an appropriate person. At the boards, however, I think it's random, and I'll defer to the other guys' thoughts as well.
It is. It's random.
Okay.
Unless you're doing a subspecialty test where it's just like, say, hand or just sports, I do believe that they try to get you in with just that substance. But if you're sitting for general, you're going to be presenting to everybody.
And then just a second question, like how much of the, in just terms looking at why people fail this exam, right? So if you've done all the stuff that you're expected to do, but on the day of, how much does it matter the fluency in the presentation? Like if you have everything documented, but you're flustered, can that impact whether you clear the exam or not? Or
I could tell you, can you guys hear me?
Yeah.
That we don't know exactly why people fail besides stories. And the stories that I consistently hear is exactly that. People who literally came there and they're unprepared, disorganized, and then the examiners you're already starting off on the wrong foot and and then what happens is then they can start asking you questions, and it just doesn't follow. I
Once
think
there's
that
no blood in the water, right? It's like a shark attack.
yeah, exactly. Then they're already not trusting you. Everything you say gets challenged. Yeah.
I mean, from hearing the presentations in the summertime at the course, there's a mix of folks who are taking it for the first time and folks who are taking it for subsequent times. And a lot of times, you're not getting very much feedback. So one of the things I'll do with the retakers is try to ask them, what is their sense of why they didn't pass? And some of them, it's obvious. They said I had a complication and I didn't address it well. And others don't have much insight. And having listened to a bunch of their presentations, there's a difference between somebody who is flustered when they're presenting and they're well prepared, they have their documentation done nicely, their T's are crossed and their I's are dotted, but maybe they're having trouble putting the presentation together, versus someone who isn't prepared at all and doesn't know the story. So, I think if you're well prepared and you did a good job and you're thoughtful with your documentation and thoughtful with the surgeries and cases that you're doing, that will show through, even if you're a little bit flustered. But if you're unprepared and you don't have the data and you don't have the documentation and you don't have answers to their questions, that's sort of a different different beast. So if you know that you sort of get stage fright and you don't necessarily do well when you're getting grilled like that, I would just take even more opportunity to run these cases by as many people as possible, do it in person, simulate taking the test, and just get reps in talking through it, so that even, you're going to get flustered, but when you get flustered, you still have all the data, you're well prepared, you know the story, you know everything there is to know about all these cases inside and out.
And there, the thing I'll mention, because this is a great question, is that, they try to fluster you, they try to get you out of sync, and like, they don't go in order. So, two examiners will sit down, they'll just say, let's go through case 3 and 7. And then the next two will sit down and go, let's go through 5 and 10. So like, it's not that it goes in order per se. Like, they're just going to tell you to present a couple and you got to be ready to do it. And then during your presentation, they'll be skipping all over. They'll be like, all right, show me the post-op. All right, go back to the pre-op, show me the intra-op. Why'd you, so you got to be able to navigate that. And then once their question is over, you then need to go right back to where you finished presenting and then start up again. So you just need to have like a very solid foundation of how each case flows, so that when they do try to throw you off, you don't get rattled. Because once you get rattled, like I said, it's only 10 minutes. Once you get rattled, it's hard to recover. So
Could you
I
end
think
up presenting
a
this?
good point. I just wanted to say, Akshay, that it's important that everybody kind of look at the scoring rubric, because they're expecting you to synthesize the information, and it may be in your chart, but also they're expecting you to do it on the fly.
Thank you.
good question.
Great. Thank you, everybody. I just wanted to wrap up here. I wanted to thank all of our panelists, and it was really terrific hearing from you all, and I hope everybody got something out of it. Like I said, we're all here if you need some brush-up help, and hope to see you in June.
Good luck.
Thank you.
Thanks, everybody. Good luck.